Assalamu alaikum. Now I would like to discuss about stroke localization. If somebody comes with hemiparesis, like weakness on that particular site, maybe upper extremity weakness, maybe lower extremity weakness. Along with the weakness, what we see is there any sort of visual problem? Is there any sort of aphasia or any sensory problems? Along with we try to find out the is there any involvement of the cranial nerves. So that's how we need to proceed if we find a patient with stroke, and we should try to localize the particular area along with its feature. Okay, look at this question. A 65-year-old girl, why came? He came, sorry, a 65-year-old right-handed man comes to emergency department. Why? Due to sudden severe right-sided weakness. So he comes with sudden severe right-sided weakness. The patient was watching television an hour ago when his family noted his face appears twisted. He also experienced weakness of his right arm and leg, but no headache, no nausea, no vomiting, no loss of consciousness. The patient has a history of hypertension and is non-adherent with his medication. He is a former smoker with a 20-pack year history. Temperature is normal, blood pressure is a bit high, 164 by 72. Oh, pulse is 65 per minute, respiration is 14 per minute. Physical examination shows right lower face and right upper and lower extremity is involved. Pupillar reflexes and ocular movements and visual field are normal bilateral. Speech is without aphasia, so there is no speech problem. So if there is no visual field problem, no aphasia, no sensory problem, looks like the stroke mm, not happened in the cerebral cortex. Then we need to go a bit down from cerebral cortex to internal capsule. On internal capsule, okay, non-contrast CT scan of the head shows no intracranial bleeding, so it is not hemorrhagic stroke. So it looks like ischemic stroke, but now we need to localize the area of the brain where it happens. Okay, if lesion on the left, like if the stroke happened in the left cerebral cortex, then it should be contralateral right contralateral hemiparesis plus these signs, contralateral or cortical signs. That means if lesion happens in the left cerebral cortex, then contralateral right cortical sign should be found along with contralateral hemiparesis. What are those contralateral cortical signs? It may be visual problem, it may be aphasia, it may be neglect, it may be sensory loss. Visual is hemianopsia, gaze preference. Aphasia is expressive aphasia, Broca's aphasia. Expressive Broca's area, Broca's aphasia. Neglect is sensory, motor, and conceptual. So neglect is sensory, motor and conceptual and sensory is contralateral deficit. uh, this patient does not have these Vance features, so it is not happened in the cerebral cortex. But if we go a little bit down in the internal capsule, what happens in here? No sensory symptom, looks like this patient, and upper motor pattern of facial loss. In upper motor pattern of the facial loss, upper part of the face, like forehead, spears, eye, spears. So its upper motor pattern of weakness is found. Okay, if it involves in the brain stem like midbrain, pons, and the medulla oblongata, midbrain for 3, pons for 6 or 7, and for medulla oblongata, cranial nerve 12 should be uh, in a consideration. Why? Along with contralateral hemiparesis, there must be ipsilateral cranial nerve palsy. So if lesion happens in the left midbrain, then contralateral hemiparesis, that means right-sided hemiparesis plus ipsilateral third nerve pulsing, that means down and out pupil. If lesion happens in the pons, then contralateral hemiparesis plus ipsilateral 6 or 7 nerve pulsing. That means lower motor pattern of facial weakness. In lower motor pattern of facial weakness, it involves the forehead, upper and lower part of the face is involved. And in medulla oblongata, left 12 cranial nerve, tongue deviation on the left, tongue deviation on the left. So contralateral hemiparesis, that means right-sided hemiparesis with ipsilateral tongue deviation, that means uh, left-sided tongue deviation. And in middle oblongata, there is no facial weakness, no loss of vibration and proprioception in weak extremity. In here, there in 12 cranial nerve palsy, no facial weakness and loss of vibration and proprioception in weak extremity. So look at now. So this patient had a stroke resulting in hemiparesis on the right arm, right leg, right lower face, right arm, right leg, right lower faces. Stroke in many locations of the CNS can result in hemiparesis, which is nearly always contralateral to the site of the ischemia and can often be further be localized by their associated feature. If it happens in the cerebral cortex, then cortical sign deficits that specially localized to the cortex. That means cortical signs means the signs, the deficits that localize to the cortex that may include Vance, visual disturbance like hemianopia, gaze preference, aphasia, typically expressive Broca. There may be neglect and cortical sensory deficit. There may be inability to recognize movement, drawn on the palm. So, cortical sensory deficit means inability to recognize movement drawn on the arm. It is evaluated with Van stroke scale. If it happens in the internal capsule, it is often pure motor, and cranial nerves are not involved except the upper motor neuron type, facial nerve, except the upper motor neuron type of facial nerve, and sensory deficits are uncommon. Brainstem like ipsilateral cranial nerve deficit, cranial nerve impacted can further localize to the midbrain, 3 or 4 for pons, 6 or 7 lower motor neuron pattern or 8 and medulla 9 to 12. The right-sided hemiparesis with upper motor neuron pattern of the facial weakness of the lower face with sparing the forehead. He has no cortical sign, so cortical stroke is unlikely. He has no cranial nerve deficits, then the facial nerve upper motor neuron type. So brainstem stroke is unlikely. That the hemiparesis is likely. These hemiparesis is likely due to a stroke affecting the left internal capsule supplied by the deep penetrating lenticulostriate artery. So this is a known case of lacunar stroke. So that's all about stroke localization and diagnosis of lacunar stroke. Hope we enjoyed.